From Redox and Healthcare Strategy Bullpen, welcome to Diagnosing Healthtech, the show where we talk about healthcare and the technology driving it with the most interesting leaders in the industry.
Good morning, Healthtech. I am Jeff Englander. I'm the founder and principal of Healthcare Strategy Bullpen. We're a digital healthcare consulting firm, and I'm delighted to be with you this morning. I am joined by our co-host, Sarah Botchin, who is the Director of Sales Enablement at Redox. And Sarah, quick question. I was looking through some stuff, but I noticed your prior title used to be Director of Sales, Virtual Care, and Patient Engagement. So you're really familiar with what we're going to talk about today. This sounds like it's going to be right up your alley.
I can't wait.
Well, it's my pleasure to have Dr. Steve North join us today. Dr. North is the Vice President of Medical Operations at Eleanor Health and the State Medical Director in North Carolina. He is the Medical Director and founder of the Center for Rural Health Innovation. He is a practicing family physician with a specialty in adolescent medicine, addiction treatment, and rural health integration. And Steve is really an early adopter of telemedicine. So Steve, if you could start off really just by telling us the story you were just talking about earlier, how you got involved in all of this, and maybe a little bit about Eleanor Health would be really terrific.
Yeah, sure, Jeff. I'm happy to. So thanks for having me on the show. And so I think that, I've always been the sort of kid who likes technology. I could program the VCR as a child. It was a Betamax, of course. But moving, further along in my life, coming out of undergrad at Wisconsin, I had the opportunity to join Teach for America and chose to do that instead of medical school, and taught school in Eastern North Carolina in the early 90s, surrounded by cotton fields and kids without access to healthcare. And in the early 90s, there was a growing interest in providing healthcare for kids at schools. And it was that idea that took me to medical school at UNC Chapel Hill. And then from there, I went to University of Rochester to do a residency in family medicine. And I stuck around and did a fellowship in adolescent medicine there. And at that time, so it's now 2004, University of Rochester was beginning to do some store and forward telemedicine. Now friend and colleague Neil Herendeen was leading that to daycare centers and elementary schools in inner city Rochester. And I really liked the idea.
In inner city Rochester.
Inner city Rochester, yeah. And they were connecting back to primary care pediatricians to sort of see the data and conduct the visit. And I saw that as a great way to do rural care. And so when I returned to North Carolina in 2006 to join a rural health center in the mountains of Western North Carolina, where I'd actually done my third year family medicine rotation, one of the draws was that they had these two little schools way out in the mountains in little crossroads, about 80 kids each, K through 8, that the clinic had started school-based health centers at, or what they called school and family health centers, that had dwindled in utilization. And I was able to restart those and actually went there and used them as an access point for folks without health insurance through some state grants. And at the same time began exploring how we could build a school-based telemedicine network in Western North Carolina, and became a fellow through a program called the Jim Bernstein Health Leadership Fellows. And that gave me some added time to build this program. Took 4 years, and in 2011, we launched in 3 schools. We did 75 visits in our first year, and the program has now grown to serving about 130 schools in 10 school districts across the state of North Carolina, in predominantly rural communities. And at the same time, I was doing a lot of addiction medicine. It's hard to not do addiction medicine in rural Appalachia. My early telehealth use, I ended up as the medical director for virtual care at Mission Health in Western North Carolina. And then in 2019, there were changes in our health system as it was acquired by Hospital Corporation America. And I had the opportunity to join a startup, Eleanor Health. And I'm employee number 9. Eleanor is a whole person, tech forward, all kinds of exciting words, place to care for folks with substance use disorders and mental health issues. And under one virtual roof, we bring together addiction medicine specialists, psychiatrists, and PMHNPs, therapists, nurse care management, peer support, to try to provide all the services that somebody needs and move from a fee-for-service model for caring for folks with substance use disorders to a value-based care or case rate type model, so that we really provide wraparound services. Yeah. And that's where I am today. We use a lot of virtual approaches to meet our community members where they are. And my nights and weekends continue to be the Healthy Schools school-based telemedicine program.
Well, Steve, thank you for doing all that, because that is just really terrific work and work that's badly needed. Let me ask you this. I am fortunate enough to know, former CEO Corbin Petro of Eleanor, and I do know from, some of our early discussions during COVID, Corbin said that, Eleanor pivoted almost on a dime when COVID hit, from almost entirely in-person care to virtual care and telemedicine. What things did you take from your experience in telehealth and in virtual care in the schools, and how did you apply that to Eleanor and what you were doing?
So one of the things that I was able to bring was the fact that you're not just having a video chat with your mom when you do a telemedicine visit. There's a presence you have to have, and if it's a third grader with a rash or an ear infection, you need to have a little showmanship to keep them engaged and walk through. And the same thing applies to adults. And how do we come as professionals, not do this from our bed? That was an early conversation I had to have with someone, but that we really, this is a powerful tool to use, even though we are not right there in the office. Unlike our school-based telemedicine program, which uses peripherals, we were just doing video work, just a video visit, but there's so much you can learn in the context of that visit that 80% of the care we provide often doesn't involve touching a patient. And it's not inferior care. You just need to know when you reach the limit. Just like anytime I encounter the kidney, I know I need to go and look something up or ask for help, because that is not my strong suit. So there may be things I can't do virtually for our community members, and that's what we call our patients at Eleanor. And so I need to ask for support, whether that be having them go and get labs, or partnering with their primary care physician, or helping them connect with primary care.
Let me ask one more, since you mentioned primary care, and then Sarah, I'll let you jump in here, because I know you have a bunch of questions as well. I teach at NYU in the Graduate School of Public Health, in the Wagner School of Public Policy is the technical name. And our, as you know, because you helped me create the project, we're doing an assignment on substance use disorder. And one of the things that one of the group has found is that I think 60% of counties, people lack primary care physicians in rural counties. And, when you're trying to direct people or who need additional care and they lack PCPs, and you're trying to integrate with them, what types of things do you do to establish those relationships, and what kinds of things can you do for them?
So building that PCP relationship is something for a community member, is something more than just go see Dr. North in Bakersville. It needs to be a bigger effort. How do I make sure that the person that I'm referring to is has limited stigma? The practice has limited stigma towards people with substance use disorders,
Mhm.
and that this individual who's doing great with their fentanyl use disorder is going to be treated as a regular person there, and not as somebody trying to manipulate the system. Also, I use FQHC Finder all the time. It's a great website to try to connect people with FQHCs, but
Mhm.
sometimes you need to find temporary ways for them to get the resources they need. And that's why in all virtual care environments, I think it's important to have people who understand that local community. That's where our peer support specialists come in. In our school-based telemedicine program, we have telehealth logistics coordinators in every school district who know the health department, know the local resources there. There are a lot of innovative programs to try to connect people with resources as well. In North Carolina, I'm fortunate to sit on the board that oversees the NC Care 360 program that connects people to resources to help address social drivers of health. Yep. So lots of parts come together, Jeff.
Great. Well, thank you. And Sarah, my apologies, but I will let you go ahead because I know you have a bunch of questions as well.
Yeah, definitely. So today's conversation is largely focused on, improving access to healthcare. And when we talk about your focus in the rural context as well as the school context, I'm interested in understanding how you got even to that first set of 75 visits. What was that process like? And what technologies were you able to start with in order to see that first success that grew?
All right. So how do we get to that process? How do we get to the point where the school system said, yes, come? Because we were introducing not only, so this is work starting in 2007 when the telehealth was unknown. And in our community, really, not a lot of people had thought about the school as an access point for healthcare. So we were trying to change two sets of ideas, or educate people and bring people on board. Lots of community meetings and stakeholders, needs assessments, and some capacity building grants from state foundations to do that work and build a model that said, yeah, where this actually could approach sustainability. So our early technology was not was piecemeal. It was a laptop that ran the stethoscope, a big video monitor, and a Tandberg computer. I'm sorry, Tandberg server that sat on the school district system. Like, we spent hundreds of thousands of dollars to outfit those 3 schools, and now, due to advances in telehealth, we could really outfit 3 schools and connect to our program for less than $10,000, probably less than 5. So it is a huge change in technology, allowing more people to have access. And I think that using schools as an access point is great, especially if you can serve the teachers that are there as well. And because that really has an impact on time away from school that they could be in the classroom. So I'm not sure about you, but when we had subs in my school, we were not as productive as when Mr. Baranowski was there, holding everything together. Yeah.
That's helpful. The TV was really helpful in the moments that
Yes.
you came
Uh-huh.
You mentioned moving from fee-for-service to value-based care and then the grants that helped you work with these schools. I'm just curious overall what the funding situation is for you, or how reimbursement fits into the work that you do. It has to be a key part of covering some of those expenses.
Yeah. So we're talking about sort of 2 different programs. In healthy schools, we're billing Medicaid successfully, doing well there. But with any school-based program, I feel that to really have an impact, you have to serve everybody, regardless of their ability to pay. And so in that environment, we have state grants that focus on safety net. that help us see undocumented kids and provide additional services. At Eleanor, one of the great things about having a value-based care relationship is that when you are meeting the outcomes that are laid out, how you reach those, you now have a whole lot of flexibility. And one of the pieces that we've learned over time is that if we have 7 or more touches, whether it be a video visit or some other interaction with one of our community members in a month, their continued engagement with us, so retention rate, which is critical, is double what it is if you have 3 or fewer. And also their success, just because they're more engaged in their own care, is better. And so that takes the form of doing scales online, using patient portal and chats, and phone calls, cases. Counting all of those things, I think, is really important. And that's why it's unfortunate that some of our health insurers are moving away from compensating for this asynchronous care or audio-only care. Aetna being a big one. I think that's really stifling innovation and the ability to provide more touches with somebody and provide this longitudinal arc of care, as opposed to just come see me on Tuesday the 13th and we'll cover everything. And then, come back 6 months later and we'll cover everything again, because you never touch everything. I think there's a lot of opportunity for folks going through transitions to keep closer tabs on them. But how we do that and how we make it survive is a challenge. The matching innovation with compensation is one of the big challenges I think we all wrestle with right now in health tech. Yeah.
100%. That segues really well into a question I wanted to ask. So I'll ask and then I'll pass back to Jeff. But I wanted to ask what your perspective is on, like, what is the ideal workflow of technology in a person's life? And this is in the context of your work at Eleanor.
Okay.
And how do you handle some of the limitations? So Wi-Fi is one that comes up a lot when we talk about like care in many settings. But I know that there are other limitations as well. I would love to hear like what you've come across that's been challenging and how you've handled it.
Yeah. So in treatment team meeting yesterday for our Texas practice, we were talking about how do we get a tablet to a homeless patient who has a patient who is unhoused, who has a PO box, but the tablet program must deliver to a residential address. And because this individual is moving from friend and family members' homes frequently, they don't have a permanent address. It can't be delivered to our office. And so we're trying to creatively think around what we could do to get the tablet delivered, and then get it in the hands of the community member. Wi-Fi is available, but how do you get somebody there to a library, to a McDonald's parking lot? And how do they have the confidential space to do a visit? So those are some of the technology solutions. And then working with the federal programs for access to broadband at home and device access, I think, is also critically important. We can't always depend on 5G service. I can take my dog for a walk, and I live in town, and I can go from 5G service at the end of my driveway to a quarter mile away, have like 1 bar and no LTE. And so just topography has a big impact on the ability to use cellular signals. But what's that ideal visit look like? Or what's that ideal journey like? I think it's this hybrid. And it changes over time based upon the needs of that patient. We need to have a set of tools that we can bring together and provide for somebody. We do a lot of work. We try to do a lot of data collection up front, so everyone on the team sees it before the first visit with the community member. Because one of the things with people in recovery and also people who have had trauma is that retelling their story over and over can be really hard for them. So how do we get as much information possible and make sure that the team reads the chart? I mean, that's not a new or technology-enabled phenomenon. It's really how do we put it up front and make sure people are acting on it. And then a combination of in-person visits. In the first month of someone's recovery, I see them once a week, and they also see our community recovery partner and engage in therapy. As they improve, as they move further into early recovery, months 2, 3, we may back down to every other week, or they're doing therapy once a week, and so maybe I only need to see them once a month. We really want to sort of adapt to what that individual needs. There was a great product that I got to use a couple of times with folks at my rural health center, and then also some at Eleanor, called Pair, which was it's called Reset. Pair is the company. Yeah. And Reset was based on contingency management to help people with substance use disorders, reward them for checking in every day. It was a great tool. However, the reimbursement wasn't there to support it. And that's why, one of the big reasons that Pair is not, or Reset is not readily available anymore. So I would love to see more use of that and more use of secure texting and pushing messaging to folks when you know that it's going to be a difficult time. New Year's Eve, how do you automatically ask somebody how they're doing? Because it's a time when lots of people are drinking alcohol, and it may set an environment for resumption of use.
Yeah, that's really, very helpful. And one of the things we talked about, kind of following up on the broadband is, my son is a reporter. He was in rural Louisiana, large number of places where you can't get a signal. And there's, I think, a misperception that if you have a cell phone, you have a hotspot. Couple things with that, but as you said, there are places you can't get a signal, and also even if you can, you get throttled down very quickly. So we were working with one group that was actually looking at putting store and forward locations and clinics in libraries. And you talked about some other places and other things that you're doing to help people get access. And I'm wondering if you could elaborate on that a little, Steve.
Sure. Through through the Center for Rural Health Innovation, we have 2 community access points in old schools that have now become community centers. One is at the school where, in 2006, I came back and for 5 years, ran one of the school and family health centers, but that school closed due to dwindling attendance. And for 10 years, I think it's been 10 years now, they have wanted us to come back, and they wanted me to come back. And that's not unfortunately going to happen, but our organization is now providing care there 4 mornings a week, and we actually have a former paramedic who staffs the clinic and facilitates everything, and it's great. So interesting, combinations like that. I'd love to see fire stations as an access point in rural communities. First responders are great people to present patients. You could put technology with peripherals there to use that as an access point. Then we get into who can you access, and platform differences, and that can be a challenge. But I think that it needs to be explored more. At Eleanor, we have bricks and mortar practices. I have community members who come to several of our bricks and mortar practices to access the ability to come see us. And I think that it is on the on the providers, it's the provider's responsibility to try to expand access. But also, I think in a shared savings environment, our insurers need to get on board with this, and they need to help provide technology and access. Because if I can prevent one ED visit for a toothache by seeing somebody virtually, or for poison ivy, they save a ton of money. They save the cost of the, $150, $200 tablet easily. So how do we find a way to share those costs? I think there's some other startups looking at that as part of their model in the value-based care arena. And I'm excited to see where those go.
And and sorry, I'll turn it back to you in one sec, but what types of things do you think you need to do or the payers need to see to be more inclined to fund some of these things?
This is one of the challenges with health services research in general is you need the long game. You need to be able to look at reducing costs over a year or 2 years or improving health outcomes and decreasing A1Cs because you've engaged somebody in a virtual program over 3 or 4 years. Not we want to see a return on investment in 6 months or we tank this pilot program.
Mm-hmm.
So that is where we need more research and more study. And that's where groups like, like Search, the telemedicine research group, and Sprout, the pediatric focused telemedicine research group, really are coming together to provide that evidence base to look at outcomes, what is quality and what are long-term benefits.
Go ahead, Sarah.
Yeah, I've got 2 questions, and one I wasn't even planning on asking, but when you're talking about providing new areas of care, it made me think of Walmart and Costco offering care experiences. I would love to hear your perspective on what we're seeing happening in the market there.
So I think access to care is great. I think that continuity of care is really, really important, especially for people who are struggling and have limited health literacy. The 3 of us, if we see a different physician every 6 months for our sinus infection or rash, it's okay. But to really address social determinants of health and have that be part of how we look at risk and risk assessment in a patient, we need that longitudinal care. So I think that if Walmart has the same nurse practitioner or physician on a regular basis and a relationship can be developed, that's great. Does that provider have the ability to refer to local resources? That's another concern.
Mm-hmm. Yeah, definitely. I mean, it segues well into the conversation around data. You're talking about continuity of care there, and then the providers needing to read the medical record before visiting the patient so they don't have to revisit that trauma. I'm interested in understanding the role you feel that integration plays. I think from a longitudinal care standpoint, some people feel like integration can help cover that, and I think a lot of folks know that it's not quite sufficient, but interested in your take on integration. How essential is it? And what do you do when it's not really an easy option?
So I think data integration is great, but we need to move beyond that into interpretation and getting the information up front, like what's changed. Just because Epic pulls in, 10,000 vital signs over the last, 48 years of a patient's life doesn't mean I have the opportunity to look at it or that I need to. What I need to know is in the last 6 months, has there been a significant change in their blood pressure? And so how is that highlighted? Or how is a cumulative story of this person's health experience presented to me? That's my big AI idea someday, but I will tackle that another day. But when the data is not there, we need to trust the patient. We need to take the time to have the conversation, whether that be a conversation through a portal and messaging, or take more than 15 minutes and actually sit down and talk to somebody. Because healthcare it's still essential to have that interpersonal relationship.
Awesome. That was the last question that I had. Thank you so much.
All right.
So Steve, let me finish up with one here, a kind of broader question. You mentioned in the pre-call that your dad was a family medicine doc. What types of things do you think hospitals and FQHCs and others who are trying to extend care need to do, and maybe even physicians like yourselves need to do to help these models work better together, with the providers, with the physicians on the one end, and then the organizations on the other? What are some of the missing links that you found, and how could you improve upon those? And how has that maybe changed since your dad's day?
Wow. My dad practiced most of his time in an era before HIPAA. And so when he was on call, he talked to patients sitting at the kitchen table over dinner. And so we knew stories of some of his patients. And I think that the influence of technology has really changed how we access information. He used to bring home stacks of charts to dictate. But the idea of what do I need, and I'm a relatively tech savvy guy. I still get 10, emails a day about new products and how it'll revolutionize my practice. I think that there's this balance of innovation and people with great ideas out there, and who can curate this and say that product A and product C say they do the same thing, but really product X is actually, wasn't an Elon Musk tribute there, sorry. Product X is actually a better solution for your practice, because we all like the bright, shiny thing. And I'm the worst at it probably, but how do we train healthcare providers to evaluate new technology and integrate it into their practice, knowing that they're going to make such an investment in this, both financially and changes in workflow, that they can't switch out in a year or two. And they're probably making a multi-year commitment. So that's one of the things that we need is an aggregator or someone to help small practices do that better.
Well, I will definitely comment on that later in the show. But I thank you very much for your time, Steve. It's really been a pleasure and a real learning experience. And I thank you. And for those who don't know, Steve's wife, Amanda, runs the Center for Rural Health Innovation. And, doing what you're doing both at Eleanor and at the center is, really much needed work. So thank you very much. And thank you for taking the time.
Thanks, sir. I enjoyed the conversation. It's great.
Thank you.
Absolutely. Have a great day.
You too, Steve. So with that, I'll turn to our quick hits and try to get through these relatively quickly, hence the quick hits. So first, and these are stories that have been fairly broadly covered in the news, and just give you our perspective. The White House has ordered HHS to collect reports on AI safety. And the White House is looking to develop a safety program for AI uses in healthcare. It ordered the Secretary of Defense, HHS, and the Secretary of Veterans Affairs to create an AI task force responsible for the use of AI in healthcare and human services. And the thing I would note here is government regulation is not going to go away. In government regulation of AI, nor is government regulation, frankly, going to go away anytime soon. I think it's going to get broader. We'll talk more in another story, but the EU has the AI Act, which is a comprehensive AI law. The FDA has been drafting guidance on AI-enabled devices. This act, it not only functions just to look at AI in healthcare and in human services, but it also expands some of the purview to talk about equity principles and security standards. And so I think that's, really something to keep an eye out for anyone who is adopting AI in their practice. And the second story leads right into this. Insiders say the latest closed-door Senate AI meeting was very encouraging. This is a series of meetings that the Congress has been having to educate themselves on the use of artificial intelligence in a number of areas, particularly highly innovative areas like healthcare. The Senate held another one of these AI Insight forums this week. Interestingly, the discussion was very balanced. There was some pushing by some elements for the Fed to create an agency to license and regulate all things AI. There was little appetite among the senators, even among some of the more progressive senators, for that. Comment I would make here is the more legislators know, or the more they want to know about something, the more they want to do something. From my time spent in DC and with the friends I know on the Hill, the more Congress learns about something, the more they want to get involved in it. And in this case, the Senate is looking to pass some type of legislation by year end. So I would be on the eye for that, or keep an eye out for that. Also in the news, ransomware attacks on healthcare facilities cost $77.5 billion in downtime. A report found on average, organizations lost 14 days of downtime due to almost 540 ransomware attacks on 10,000 hospitals between 2016 and mid 2023. The ransomware demands varied from 1,600 to 10 million, and the average cost of downtime was relatively flat this year. The average cost was 15.5 million in 2023, 16.2 million in 2022. That was way up from 2021, where it was 9.4 million. Approximately a quarter of providers saw a rise in mortality due to ransomware attacks. This was from a study in 2021 by the Poneman Institute. So it shows again the importance of cybersecurity as you're moving to all things. We talked about interoperability in this podcast, talking about moving to data to the cloud. Anytime you're using data, moving data, cybersecurity remains your top priority. Also, another report on AI. As you can see, a number of themes are developing here, but a report from Moody's that AI can improve the revenue cycle but increase risk. Moody's says that AI has the potential to improve revenue in terms of revenue cycle operations, labor efficiency, and cut burnout. But citing similar data, they indicate that it has the potential to increase the risk of cybersecurity attacks and patient data breaches. One of the things they do know is they expect this to increase investment in IT, but also shift possible spending as spending on generative AI increases, but spending on storage and servers gets pushed out. And also you could see some delays in upgrades. This could change a competitive landscape for hospitals that are integrating AI into the business models. Cited a number of hospitals where they're doing some very interesting things. Mercy Hospital and Microsoft are implementing generative AI-based communications to help patients build and better underserved lab results and schedule follow-up appointments. Mass General Brigham is collaborating with GE Healthcare on an AI algorithm to predict missed care. And New York Langone has its own homegrown large language model to cut readmissions and hospital-acquired conditions. I think that the early investments in AI are going to continue to focus on lower risk areas and non-clinical applications. And our last story, which we will talk about in a couple of weeks, is global digital health funding hits its lowest level since 2016, the report finds, but worldwide digital health funding has really slowed down. It had 10.2 billion this year, only 40% of last year's total. A little over 1,000 deals have closed in 2023. That's about half the deal count of 2022. Lowest level since 2014 and 2016. Care delivery and navigation had the lead in volume, about $1.3 billion, followed by monitoring, imaging, and diagnostics, about 7.7 billion. Drug R&D tech spending was about $500 million. So the buyers are looking for integrated solutions, moving away from point products, which is hurting a lot of companies. We think the market is ripe for consolidation as companies run short of cash runway. And I think you're either going to see consolidation and M&A or an increasing number going out of business. As you saw recently, one of the things we'll probably talk about next week is all of AI did essentially go out of business, selling a number of their assets. There'll be more companies like that. And with that, I will now turn to our articles for discussion. And Sarah.
Yeah, I've got two for us today. So the first is there's a new survey that found that most healthcare professionals see health equity as significant, but less than half think the current system can effectively address it. So definitely a prescient topic for the conversation that we had today. The respondents, so it was around 53%, really were looking to things like social determinants of health as being a key barrier um, to patients actually experiencing health equity, and affordability was a key item that they commented on. So the actual cost of care is a huge barrier. But today we talked about, things like being able to access technology, having the space to participate in healthcare. I think even for a very health tech or tech forward health system, and with the price transparency work that's happening right now, it's still almost impossible to know what you're going to be paying for. And I've had this experience myself this year trying to plug in, the CPT codes that I think are going to happen when I go to a visit, just out of curiosity to see what it comes up with. And it eventually always ends up being a phone call if I want to know what I'm going to pay for. So
Yeah, no, and I think that one of the other elements, in addition to cost, that the article brings up is it's really difficult for providers to connect into some of these other areas. For example, it's very hard for a doctor to write a prescription for housing or for food, and those are areas that we need to have the healthcare organizations better integrated into the community. Also, Steve referenced it in terms of people who are very well meaning, wanting to do things like make sure if you're supplying a tablet for someone who is unhoused, that it goes to a residential location. But these people often are moving from place to place and they don't have a residential address. They may have a P.O. box. So thinking about that, we worked with one group where they were trying to get paper records from people. And it was very difficult because most people, they don't have a printer. Even a large number of housed people don't have printers. They don't print out 3 months worth of records. They don't have them to bring places. So they may have them on a cell phone. So thinking through all of the implications of not only well-meaning intentions, but also intentions to prevent fraud and deceit and theft, and the impact that these could have on the ability of the program to serve what you want it to do.
And I think a big part of it is they're acknowledging that the system right now is just not situated to address social determinants of health meaningfully. I think that comes down to technology, it comes down to access in general, but also just reimbursement of the services that would let, it be possible to participate in care, things like transportation. So
Yeah, and the one other point I would make is I know there was a very successful program years ago in terms of reducing homelessness in Houston, and they had to combine both the healthcare organizations, the providers of housing. In this case, it was a large apartment developer, with the communications provider, which I believe was AT&T, and it was a wide community effort that allowed them to address all of these issues, of which the health organization was part, and may have even been stewarded it, but they weren't able to do it all themselves. And I think that's important.
Well, we're almost at time, so I'll go through this one quickly, but it's a biggie. So we finally have the establishment of disincentives for healthcare providers that have committed information blocking. So the new proposed rule was released yesterday by the U.S. Department of Health, and it details the first steps for holding healthcare providers accountable for information blocking. There are a couple things that are really interesting about this to me, but there is going to be an information session on November 15th on the proposed rule if folks are interested in getting into the nitty gritty. And it's going to be open for comment up until January 2nd. So once you've, listened in to the details, you can comment on the rule. I think the biggest thing is they're breaking out the groups that will be held accountable. I think from my end, the thing that's always challenging is being able to have appropriate and broad coverage where all providers are held accountable, and that's something that I think that they're working on here. But in the breakouts of how they're kind of defining the actors that are being held accountable, it's pretty specific in nature. So that's all I have to say really about that.
Yeah, I'll just add quickly. Sarah mentioned the comment period, and two things is most of the penalties are tied to MIPS and other programs and reductions in the market basket. And I think that's all appropriate. And so if you don't think that is, or you don't think that they think they could be better, I would comment on that. What I also would encourage people to think about is what's the practical reality of how these things are applied? Because if you need to or have to work with a provider and they don't get you the data that you need, are you going to go ahead and sue them? Are you going to go ahead and file a complaint? So what other options might they want to put in the regulations for facilitating this, so to make the system work better that may not be punitive? And that would just be, one of my ideas there.
Awesome. Thanks, Jeff.
Well, thank you, Sarah. Thank you for joining us today, Sarah. I thought it was a great discussion. As I said, I'm Jeff Englander, founder and principal of Healthcare Strategy Bullpen. Going to divert a little from our usual kind of ending. As Steve talked about, one of the things that I think would be really helpful, and one of the reasons we exist, is to help people and help providers on one end figure out what's the right technology. We do a blog every other week called Scouting Report, keeping up with our baseball analogy for those who know us. And it talks about an up-and-coming health tech company. This week, we talked about Eleanor Health. And what we try to do is help payers, providers, Medicare, Medicaid, understand the differences in some of the technologies, help them curate what are the differences in the technologies, help them figure out what is the right technology for them, for their network, for their technology stack. Because if something is the bright shiny object for somebody else, it may not be the right thing for you. So, please let us help you adapt and deploy healthcare technology to improve the lives of your patients. And please do reach out to us at healthcarebullpen.com or on Twitter at healthcarepen. And feel free to look us up on LinkedIn. And with that, I will turn it over to Sarah.
Yeah, thanks everyone for joining us. This is also sponsored by Redox, the leader in healthcare data integration. We heard Steve talk about elevating technologies and making data useful, and that's exactly the function that Redox tries to serve. We exist to make healthcare data useful, and we do it at scale in healthcare. With that, I think thanks all for joining us, and we'll see you next time.